now that we're seeing ibrutinib and other BTK inhibitors used as frontline therapy, the question comes up, what do you do with patients after that? We've seen a lot of very good data from Vanetta Clacks combinations. Most prominently, the Murano data shows that the combination of Vanetta Clacks plus rituximab is superior to chemoimmunotherapy, this time with bendamustine rituximab. So there was a superior progression-free survival and overall survival in those patients who were treated with that combination. So that's what I tend to do. I tend to use venetoclax combinations after frontline therapy with ibrutinib. There are many venetoclax combinations that are being studied. We've seen data with venetoclax with rituximab. There's also venetoclax and obinutuzumab that's been published in that setting, and I think that's also a very important combination. So I think the most important take-home message for community oncologists who are treating high-risk patients is to embrace some of the newer therapies, to get away from the therapies of the past with chemoimmunotherapy. We know that from these studies that I've just mentioned that the targeted therapy with a BTK inhibitor improves outcomes for patients with these high-risk populations. I think another thing to suggest to the community oncologist is that if things aren't going the way that you think they should be with this high-risk population, then you're going to want to send them to a center of excellence where they see a lot of these patients. I think it's also reasonable if someone is refractory to ibrutinib, they're progressing on ibrutinib, to seek a second opinion or a consultation at that time, because many times there's an underlying reason. Is that reason because they have a CYS481 mutation and that using one of the new alternative ibrutinib, one of the new alternative BTK inhibitors might be of help? There are a variety of reasons why patients might become refractory to ibrutinib, and trying to figure that out is important. The treatment landscape for CLL is evolving rapidly. Today, we're now using ibrutinib as frontline therapy for patients with chronic lymphocytic leukemia. But I'm not sure that's what it is tomorrow. We know that one of the disadvantages of placing patients on ibrutinib is they tend to remain on this therapy for indefinitely. And that's difficult for many of our patients to swallow, right? Taking a pill for forever, even if it does make them feel much better, even if it does put them into remission, is a challenge. We now have seen several studies with combination data. They're generally in combinations with venetoclax, where patients can be treated for a limited time with a combination regimen and then come off treatment. Most prominently, we've seen the data from the combination of venetoclax with obinutuzumab that was recently published in Blood that showed a 100% overall response rate in the frontline setting with MRD negativity of 75% in the bone marrow, 75% in the blood that is maintained over time. This is an exciting combination, and we'll see data from CLL14, which is conducted by the German CLL study group, shortly. This is a randomized phase 3 trial that compared that combination that was published in the phase 1 population in a phase 3 setting, comparing it to obinutuzumab with chlorambucil. And so we know from press releases that this was positive, and then frankly, it's hard to imagine why that wouldn't be positive data. But the more specific information about the depth of the remission will come out. So that's one combination that will likely change the frontline setting. I think another setting, another combination that's being studied is the combination of venetoclax with ibrutinib, and this also has in early studies and early results showed a very high complete remission rate and high MRD negative rate. Now there are also studies looking at all three drugs, obinutuzumab, venetoclax, and ibrutinib, and time will only tell about whether that 3-drug regimen is more important than the 2-drug regimens. And frankly, which 2-drug regimen is the best is not clear. You can imagine that using 2 of these oral agents might be fairly expensive and difficult, and therefore might face some challenges from patients and their physicians in implementing this as a frontline therapy.